Hello and welcome to Alumni Weekend 2020 Reimagined. I'm Chris Moore. I'm the Dean of Sargent College. Thank you all for being here. While none of us imagined we would ever be zooming in for our celebration of Alumni Weekend, I'm enormously grateful to have this option. It's heartwarming to see how many of us would rather be together virtually than to be apart for this important annual get-together. Thank you for making the time to join us and to reconnect with your Sargent community. Despite the challenging circumstances, I have lots of good news to report. So before I turn the program over to our distinguished speaker, I have just a few highlights to share. Currently, BU and Sargent are back to business, educating our students without interruption. And in fact, despite the extraordinarily challenging circumstances that COVID presented to all of us last spring, I'm extremely proud of the progress all of our students have made in reaching their academic objectives. In fact, with BU's Learn from Anywhere model, our residence halls are occupied, albeit at COVID-induced reduced occupancy, and our graduate enrollments are the largest in recent history. Students are adapting to BU's LFA model. Students who opt to do so are attending classes in person, while others are zooming in from around the world. It's inspiring to be a part of this extraordinary time in education, where the remarkable creativity and flexibility of our students and faculty are revealed for all to see. The value of your Sargent degree continues to grow. Sargent's program's international stature also continues to grow. In the most recent US News and World Report rankings, OT retained its #1 position. Speech language pathology moved up to #10. And the DPT program came in at #20 in an increasingly competitive marketplace. Sargent is the whole package: undergraduate, graduate, and PhD education, future-looking clinical services, intensive research operations, and we're increasing in almost every domain. Sargent is preparing the clinical, academic, and research leaders of the future. Our faculty research programs continue to excel even in an increasingly competitive and decreasingly funded environment. This past year saw $18 million in external research funding at Sargent, and we've nearly doubled the support and enrollment of our PhD programs. Our student population continues to expand with more than 1,200 undergraduates and over 600 graduate students. We currently host the 4th largest undergraduate major at BU, Health Science, which in the time of COVID is more relevant than ever. And more Sargent graduates by far go on to graduate school than any other college at BU. More than 40% of our undergraduates pursue graduate studies across the spectrum of health careers. We're devoting more energy than ever to our new initiatives in diversity, equity, and inclusion, some of which are supported by over $35 million in gift support since I joined the college back in 2014. While I could, and I would desperately love to discuss each and every one of these topics in greater detail with each of you, as we did in the town hall webinar last week, there's no time for that today. We have much more exciting things in store. But if you're interested, I would encourage you to visit the video recording of that webinar, which is available on the Sargent College website. Now it's my genuine pleasure to introduce our much loved Carolyn Cohen, Sargent class of 1965, our Alumni Weekend representative from the Sargent College Alumni Association Board. No alumni gathering is complete without a word or two from Carolyn. In a previously recorded message, she will introduce today's speaker. Carolyn, take it away.
Welcome to our 3rd annual Sargent Symposium. My name is Carolyn Cohen, and I graduated from Sargent College in 1965. It is my pleasure to serve on the Alumni Association Board as chairman of the Alumni Weekend. I've put aside my signature hat and gloves and greet you all remotely. This reunion is historic, first online and remote. I am glad you joined us. Several years ago, I gathered a group of past presidents of the Alumni Association around my dining room table, and together we created an educational component for Sargent's Alumni Weekend. The symposium concept was created to emphasize the continued quality of teaching we all experienced and still is the norm at Sargent College. In the keeping with the traditions of Doctors Gardner, Powers, and McGarrett, the Alumni Association selected senior lecturer Kelly Passanelli. Kelly is currently a lecturer in the Health Science Department. She graduated from the College of General Studies in 1994, received her bachelor's in physical education from Sargent College in 1996, and her master's in physical therapy from Sargent in 1998. She is also our new president of the Alumni Association. Professor Passanelli will present a program entitled COVID-19, Lessons Learned and Looking to the Future. She'll be joined by a panel of alumni who are working in the field with those affected. I hope you enjoy the presentation and join us at 3 p.m. for the Sargent College Alumni Awards. I'm also grateful for the enthusiasm and the support of Dean Moore and his staff. So now, let's listen.
Thank you, Carolyn, for that introduction. I have such fond memories of being a student in Sargent and having Carolyn teach me CPR in the basement lab of Sargent. So Carolyn, thank you. I'm going to begin to share my screen now. I'm going to give you a brief overview of what we're going to be talking about today, introduce you to my panelists. So today's talk, COVID-19 lessons learned and looking into the future. Carolyn, thank you for introducing me. I want to take a minute now to introduce my panelists. So the first is Dr. Judy Lytle. Dr. Lytle is a clinical assistant professor of BU School of Medicine. She is a med school graduate, did considerable amount of work in Sargent with actually Gary and Margaret Squiner some years back. She is a primary care physician in Boston, now practicing on Commonwealth Avenue. Lindsay Stevens was a student of mine and graduate of Sargent Health Sciences program in 2018. She's currently enrolled in the master's program at our School of Public Health, and she is the care coordinator in clinical and recovery services at the St. Francis Day Shelter here in Boston. Jay Trivedi and I actually overlapped a little bit at our time in Sargent. He's a graduate of our human physiology program and is currently the chief executive officer at the Uppermost Corner Committee. So first, thank you to my panelists for being here today. Thank you for donating your time to talk about such an important topic. What I want to start off by doing is talking a little bit about COVID-19 and the social determinants of health. So as we all know, COVID-19 originated in Wuhan, China. These statistics are current as of this morning at 7:15 a.m. Eastern Standard Time. Worldwide, COVID-19 has affected over 34 million individuals. There have been over 1,000 deaths worldwide. Domestically in the United States, we've had over 7.2 million individuals testing positive, and we have lost over 207,000 lives. Locally in Massachusetts, we've had over 130,000 individuals infected and have lost over 9,000 residents of the state of Massachusetts. So I want to start off just, giving a brief overview. What are the social determinants of health, and how does the World Health Organization define the social determinants of health? So the World Health Organization says that the social determinants of health are conditions where people are born, grow, live, work, and age. These are shaped by the distribution of money, power, resources at a global level, a national level, and a local level. So what are the social determinants of health? There's 5 main categories for the social determinants of health. 1 is economic stability, 2 is education, 3 is social and community context. 4 is health and healthcare. And 5 is neighborhood and the built environment around you. So when we think about economic stability, okay, we think about individuals who may be living in poverty, maybe living under the federal poverty line, of 139% and recipients of the United States Medicaid health insurance. Economic stability, as we all know, as a result of a pandemic, there are millions of individuals that are out of work right now. Millions of individuals in the United States have their health insurance tied to their employer-sponsored health insurance. So individuals who may be out of work right now may not have access to their health insurance through an employer anymore. Food security, housing stability. For those of you that are keeping up with the news in Boston right now, Mayor Marty Walsh announced yesterday that the eviction moratorium in Boston is set to expire in October, which is going to disrupt housing stability in Boston. Education. Individuals in elementary schools, high schools are learning from anywhere right now. Our access to education is a social determinant of health. Language and literacy is a social determinant of health. Thinking about social cohesion, thinking about access to care, thinking about, as we have Dr. Judy Lytle here with us today, access to a primary care physician is so unbelievably important. Lindsay's going to talk today about access to healthy food and work that, she has done in conjunction with Project Bread to try to get healthy foods to individuals in need. Quality of housing, crime and violence, and environmental conditions are all very, very, very important social determinants of health. So what factors influence health? Okay, so what you can see here in the middle is your age, your sex, your constitutional factors are at the center of that circle. But most importantly, to look at the outskirts of that circle. Your socioeconomic status, your culture, and your environment have the greatest influence on your health. And then just under that is our living and working conditions. What work environment are you in right now? What does your education look like right now? Do you have access to education right now? Do you have access to technology to allow you to access curriculum that now for most is in an online format? Are you unemployed right now? Do you have access to clean water and sanitation? Do you have access to healthcare? Do you have access to housing? And then last, I want to talk a little bit about the health impact pyramid. So what you see here on the bottom is socioeconomic factors. So when you address socioeconomic factors, you have the greatest impact on a population with the least amount of individual effort. Okay, so having an impact on a population with the least individual impact would be addressing socioeconomic factors. Okay, and at the top what you see is education. So looking at socioeconomic factors has the greatest impact on individuals' health. I want to start now in a minute by talking to Dr. Lytle about her experience. What I do want you to know is our question and answer feature is open. So please feel free as questions come to your mind to type them into our question and answer. I will be discussing the panelists' work with them first, and at the end we will do our best to save time to answer your questions, but please feel free to type them in at any time. So Dr. Lytle, thank you for being here. Can you take me back to the day in March when you were asked to provide care, provide services to individuals at Boston Medical Center in the former East Newton Pavilion that were experiencing homelessness?
Yes, and it was a bit of a personal journey to get there. I, in late February in my own practice, had the opportunity to take care of one of the Biogen cohort from the Marriott Long Wharf meeting about which so much has been published. And before I think any of us really had much of a sense of, what the implications of COVID were going to be, I had the privilege to the eyes of this biological scientist, this PhD scientist who works for Biogen, who in fact became COVID positive. I had the opportunity to follow the course, the natural history of her acute illness over a period of weeks. And obviously, we didn't have her come into the office. She, through Biogen, had been tested and we knew she was positive. So, that alone was a leg up over what a lot of other people have had the opportunity for. She was able to be tested and had, early recognition that she did have COVID. But through a series of texts and checking in with her day to day, we managed her in her apartment in the Back Bay. She didn't eventually need to go to the hospital, but I had the opportunity to really, day to day kind of experience what the natural history of this newly emerging pandemic disease was going to look like. Our office closed and we were beginning to try to figure out how to manage, our primary care delivery through, at this point, just phone visits. And in that 2 or so week process, like everybody else, I was getting out and walking. I think, the sourdough bread making hadn't yet really started, but I was getting out and walking with my husband and dogs and, trying to make sense of it. But I just was having this real conflict about being a primary care internist in Boston and feeling the need to make a contribution. And I just was struggling with this, day in and day out. I started to get a series of emails from the medical center requesting volunteers, physician volunteers. And, this just heightened my conflict around the fact that I needed to be stepping up and doing something. The problem was at this point, everybody was so inundated and so busy and so trying to figure it out. I couldn't really get anybody to tell me if I were to volunteer to go and work in the hospital, what my role would be. And my worry was not so much about COVID, but about being thrown into the ICU where, I haven't managed ventilators in 20 years. So my worry was about not putting myself in a situation clinically where I really wouldn't be well prepared. So I continued to kind of, see these emails and kind of sit on my hands, just feeling more and more conflicted about it. And I think it was later in March when I saw an email that just really struck a chord with me. It was a call for physician volunteers to help to staff what was going to be a new unit in the, as you mentioned, East Newton campus, which has been decommissioned, but was open for this purpose. And the purpose of this unit was to house housing insecure or homeless individuals who were COVID positive, but not ill enough to require hospitalization. So I knew immediately that this was something that probably was the right fit for me. And so I went the following day or 2 days later for an informational meeting, and it was a room full of people who were just really inspired and inspiring and had, certainly more than I, a lot of experience with the homeless and housing insecure populations, as well as many people that worked with substance abuse. I sat at this meeting and, with a little bit of trepidation, thought, I need to sign on for this. This is my place. And did so on a Thursday, late afternoon at this meeting, and the unit opened on Friday. So I didn't step in quite that immediately, but the following week, beginning the following week, I signed up for 2 12-hour shifts a week that continued through the end of May and into June. And I was fortunate in the sense that my office gave me coverage for my patients so that I was able to do this. So that was a big bonus, that I was able to do this because my practice kind of stepped in and helped to cover my patients. So that was kind of the way that part of it came about.
So what was the patient population like that you were working with in East Newton?
So, and again, my kind of fantasy was that I would go in and be able to sit at the end of people's bedsides and kind of hear their stories. These were many, many, many people from Pine Street and other shelters. A handful of people who, although they weren't homeless, had housing situations with in some cases, many times more people than would be reasonable for a 1 or 2 bedroom apartment. In a couple of instances, I remember one gentleman that had a mother who had end-stage lung cancer, and he was trying to protect her. But in general, they were people who didn't have housing or family resources to support them in their, quarantine and in their isolation while they, either waited out their quarantine or recovered if they were ill from COVID. There were, I would say, a high percentage, not all, but a high percentage of the patients that we took care of were people with substance use issues. I learned a great deal about the chain of custody of methadone, but I think most specifically it was just major amplification and kind of distillation of the factors, social determinants that affect all of us every day, everywhere, but just in a really distilled version in this setting with COVID in, Boston in shelters.
So you talked a little bit about individuals that are using substances and having that being a social determinant of health. Can you talk just a little bit about your experience with that, individuals using substances and, how that may have impacted their course of COVID or?
So, I mean, it certainly impacted their journey with, the burden of COVID disease. It also impacted the way in which we were able to take care of them. The East Newton Crew Unit, as it was called, the COVID Recuperation Unit, was actually the idea of and was, put together by some clinicians, Miriam Harris and Miriam Koromarami, who are involved with the Graykin Addiction Center, as well as with some other providers that are closely involved with Boston Healthcare for the Homeless. So the idea actually for this unit derived from the, just the knowledge and the experience of people that work directly with homelessness and with substance use issues. The degree to which it kind of impacted the day-to-day, we had to make accommodations for people's methadone. If someone was admitted to the hospital, we had to make arrangements to either get their methadone from their outpatient clinic. If they were discharged, we had to make arrangements. So a lot of the care and management of this population revolved around, their medications as relate to their substance use. There were a high percentage of this population, not surprisingly, with behavioral health issues. There were lots of a high percentage of patients who smoked, and there was, I would say, just a really appropriate and respectful arrangement, although smoking certainly isn't recommended, and it kind of goes against the theme of my work with patients in my office. The respect for these individuals who were smokers, and arrangements to give them a safe place outside on a every hour, a couple hour basis to have a cigarette. So there were ways in which our care revolved around considerable respect for these individuals, and I think a level of caring through demonstrating that in some of the things we did for them.
I know one of the things I always admired about you is your holistic approach to the care of a person.
Yeah.
You're not just a primary care provider that, sees somebody with a sore throat and says, okay, here's penicillin, bye. You really get to know the whole person. Can you think of maybe one patient story? You are the person that wants to sit at the end of the bed and really get to know them. Did you have the opportunity with any of the patients that you treated to get to know their story that you might be able to share with us?
So yes, but not in the sort of fantasized way that I had hoped. There was a, each day was, or each shift was kind of a challenge to pull together the various individuals. And I need to say that that was one of the highlights of the experience, was working with the people who stepped up to volunteer for this. But I often would hear through their eyes, medical assistants who were the ones taking, people their aspirin or their Tylenol if they wanted it. I often heard through the eyes of some of these wonderful volunteers, or through the ears and accounts of these wonderful volunteers, as much as my own, although I was present, there was a lot of organization to be done just to kind of maintain safety for people and make sure that people were, not putting themselves or others at risk. So as a kind of coordinator, I felt like I was at times kind of running around putting out fires more than I was able to sit at the end of the beds. But through the eyes and ears of some of the wonderful other people volunteering, I remember one young man that was blind as a result of having tried to commit suicide by shooting himself, and he had failed in his suicide attempt, but was blind as a result. I remember the job insecurity was certainly, lesser of a proportion of what these individuals struggled with. I mean, for many of these individuals, just, having a place to sleep day after day was the challenge. But there was a hardworking man from Morocco who had a, self-sustaining job in the food industry, but because of, the restaurant industry being shut down, he had lost his job. There were, trying to think of other, I think the extent to which I was able to sit on the end of the bed didn't happen in the way that I had hoped, but it certainly, there certainly were reoccurring themes. And I think the extent to which people had incurred just considerable losses in their lives, and who maybe hadn't always been, disadvantaged in the way of housing, but who had found themselves there because of life circumstances, is probably the theme that was predominant.
Yeah, and an important one, especially seeing in Boston this coming month, that evictions may be happening. Thank you. Thank you for your work. Thank you for being here with us. Lindsay, I want to turn to you now. And I'm going to ask you the same opening question. Can you take me back to the day in March when you found out that you could not return to your work the next day at St. Francis House, and what that was like for you?
Sure. So just a brief kind of summary of what St. Francis House is for everybody. St. Francis House is the largest day shelter in Massachusetts. We serve roughly 500 or so people a day. And we help them with just, the basics: access to a shower, access to clothing, access to food, access to a stable mailing address. And then we also offer some more intensive services: case management, therapy, access to an outpatient medical clinic, workforce development and employment services, and recovery and support services as well. So there's a lot going on in one building. And the day I found out was Sunday, March 15th at like maybe 5 or 6 p.m. I got an email from my supervisor that simply said, "We are not to return to work." And we're going remote. The shelter will be immediately operating on reduced capacity. Only essential workers will be on site, and only essential services will be offered. Essential services meaning mailing, food, emergency clothing, and showers. So my immediate reaction was just sheer panic, because in a typical day-to-day, my job really requires me to be present on site. I am an outreach worker, so I'm very much in the community, going with clients to appointments, going with them to court, helping them be able to interact with certain services. And another thing with a lot of my clients is they do not have access to technology to keep in contact with me. They do not have access to a cell phone. If they have access to a landline, it is only for maybe 10 or 15 minutes before they have to give it to someone else for their turn. Same thing goes for computers. And this is only during certain days that you were there to get up, like you were able to sign up on time. So my first, most immediate reaction was, how am I going to reach everybody? And I panicked over that for a while. And I kind of stared at my email for answers, and we were just furiously emailing back and forth about how we, with the very, very limited people we had on the ground, would be able to reach the enormous population that we serve. And over time, I was able to work out a system with staff present, in the community where I could ask a patient to, call me every Wednesday. I don't know where you are. I don't know where I'll be. Just call me, leave me a voicemail, like let me know what's going on, and I'll find a way to get back to you. And those of the patients that did have phone access, I would say that was probably the most essential landline I had to everybody.
So the areas that you felt when you got that phone call, here it is on a Sunday, you can't come into work on Monday. So the areas that were impacted the most for your clients initially. So you said, just access to technology and being able to keep in touch with people. What would you say are the two other areas that you saw initially had the greatest impact on your clients?
The other two areas that I would say were very, very much impacted were access to other services. For example, like local government offices, Social Security, where people can get their Social Security benefits and disability benefits, Department of Transitional Assistance, which applies to SNAP, which is a supplemental food program, which is how people get access to food. And court was shut down. Every local office that you needed to interact to get the basic needs that you needed were no longer operational. And to get through to them on the phone was incredibly difficult. Very long waits. And like I said before, a lot of my clients do not have the option to sit and wait. Like you're on a set schedule before you have to move on to the next thing that you're trying to accomplish before you have to get to shelter for bed lottery at 3. So it was definitely access to services was one of them. And I would say that the other one that was very heavily impacted was access to shelter and medical care. So with the access to medical care, it's just the way to go about connecting with clinics changed. And this population relies very heavily on word of mouth and established routines. So when that all got upended, a lot of people did not know, how do they connect with their primary care doctor? They don't have a phone. They can't call into telehealth. What do they do about all the specialty appointments that it took them months to get referrals for? And all of that all of a sudden went out the window. And regarding access to shelter, I mean, on a regular day, access to shelter, you present to the shelter, you go through triage, and if based on availability, you get a bed. That changed with COVID. A lot of the major shelters were not accepting new clients, and if they were, you had to go through hoops proving that you were COVID negative, getting multiple tests, which at the time was incredibly difficult to do in a time period where that would be worthwhile.
Yeah, I think this is a great transition to Jay. So at Upham's Corner, can you take me back to that day in March where you were notified that life had to drastically change?
Sure. Thanks, Kelly. And just kudos to Judy and Lindsay for the, direct patient access that they provided throughout all this. It's workers like that keep me motivated from doing the work that I keep doing day in and day out, because I don't get the privilege to serve patients anymore in that same capacity. So I'm just always grateful for providers out there. So just before I take us back to the day in March, I'll give a little history on Upham's Corner Health Committee. Upham's Corner Health Committee is in Dorchester. It was founded by community members and is committed to providing high quality, low cost, culturally sensitive, community-based health and social services, primarily to the residents of North Dorchester, but also over the years to the adjacent neighborhoods. Currently, we serve about 12,000 patients and have at the community health center about 60,000 or so patient visits annually. About 50% of our population that we serve are 200% below the federal poverty level, and about 25% of the service area population that we serve is 100% below the federal poverty level. We serve over 5 languages, 60 of our patients are female, 40% are male. They range in age from birth to over 80 years old. And, it started in 1971. And the primary reason the health center and the health committee formed was because primary care providers were moving to the suburbs. We opened our doors in 73 at 500 Columbia Road in Dorchester, Mass. And we had one primary care session a week and 2 pediatric sessions per week. And the services that we provide at the health center are primary care, internal and family medicine, pediatric adolescent care, women's health, including prenatal and postnatal, urgent care, behavioral health, substance use, addiction services. We have a full BH department. We offer planning, family planning, a nutrition department, social services, just benefits assistance for individuals of the community, not even necessarily our own patients. We have a pharmacy on site, radiology and lab services, both through Boston Medical Center. We have a dental clinic and eye clinic. We have women, infants, and children, a WIC program that we serve, as well as serving the support of WIC in the Mattapan Community Health Center, the Harvard Street Community Health Center as well. And we have a Hyde Park location. So that's the primary health center, full service clinic. And then in 1996, we opened a PACE program. And PACE is a federally run program regulated through Centers of Medicare and Medicaid Services. And it stands for Program of All-Inclusive Care for the Elderly. And it is to provide comprehensive and continuous health and social services to support the independence and nurture the spirit of older individuals. And we work in close collaboration with the community and family caregivers. And it has a full interdisciplinary team: primary care physicians, nurse practitioners, nurses, nurse case managers, PT, OT, BH, and social workers, a transportation team, a PACE center where people can come in 3 to 5 days a week and they see all those clinicians. We have dietitians on staff, pharmacists on staff, and center-based aides, as well as home health aid services. And just to piggyback off the home health aid services, the organization, we also started in 1975 a home health care program, commonly known as a visiting nurses program, a VNA. And we provide care to those individuals in our immediate service area as well, for those patients who are homebound, not just nursing services, but also OT, PT, home health aides as well.
It's a great background to just see how many services you offer and how much was probably impacted.
Right. It was quite a bit impacted. And you mentioned the day back in March, which I remember March 10th as the day the governor declared a state of emergency for Massachusetts. But we actually had started planning, because in the healthcare field, we started planning back in January. We started hearing what was happening in China, and we knew we wanted to be prepared. So when we first heard of the novel coronavirus, we started purchasing hand sanitizer and started adding additional hand sanitizer dispensers throughout our clinic spaces. We have 7 buildings, all within 5 miles of each other, but we have 7 facilities. So we wanted to make sure we had those. We checked our emergency preparedness stock for face masks and face shields, and particularly N95 masks. We started calling patients and asking them, if they were having signs and symptoms of fever, as we were all still learning and being educated on what coronavirus, COVID-19, SARS-2, name it what you want, with all of its names. We were trying to do that, and we were educating our staff and our patients as much as possible. So, that was in January. We started reaching out to our suppliers and started trying to prepare that way. In mid-February or so, I believe we heard that there were about 15 cases in the US and there was one confirmed case in Massachusetts. I think the date was February 19th, sticks in my head. But the case, we were kept being told that it was still a low risk in Massachusetts. So, through end of February, we were being told it was still low risk. In the beginning of March, we knew that was quickly changing. And so we activated our COOP plan, which is a continuity of operations plan. It was our emergency preparedness plan. And we really started focusing on our governance, our supplies at a higher level of detail, because not just PPE supplies, but regular cleaning supplies, employee relations we started looking at. We started looking at our patient flow and operations. Financial impact became a growing concern for us as a nonprofit, community-based organization. Started looking at our facilities, our communication patterns and planning. We looked at our technology, which is a huge component of this for us. And then we started
seeing how many individuals you treat in a given year. How were the patients impacted by this?
So the patients were severely impacted. The patients continue to be impacted, and it's really on how we try to continue that access that Lindsay mentioned. It was, how do we get in touch with those with the limited resources that we had? We are a high-touch, in-person organization, and we had to shift into this tech-based company without the resources. Back then, things have progressed quite a bit since then for us, but back then we had to figure out, how do we get in touch with our patients? They don't have cell phones. They didn't know how to access telehealth. They didn't know how to access the electronic health record, even through a portal, because they hadn't been trained on it. They don't have the access. So it became a shift. So we started outreaching. We started calling. We started providing our advocate team out, reaching out to individuals, calling every single person that we could to get a hold of them. But people's numbers were changing. They had cell phone numbers that would, have only X amount of minutes a month. And they wouldn't want to answer the phone because they wouldn't want to burn through their minutes sometimes. So that piece really impacted the patients that we were serving as well.
Yes, so access to technology is such an important social determinant of health. If you can't get in touch with your provider, it prohibits your access. So some of the support services, outside of direct patient care, that you offer to your patients at Upham's Corner, what are some of the other services that you provide to patients, and how are those impacted?
So some of the other services we provided, food pantry, something that we popped up, which we didn't have fully established because there's so many great community agencies that already do it well. But people were so afraid to leave their homes, didn't really know and didn't trust where to go, so they would go to where they knew best. So we opened up a food pantry. That was a piece that was something that we started providing and continue to do, trying to work with the patient when they would come in to read a document that they didn't fully understand, something that Lindsay referenced, working with those patients and clients, how to read overdue gas bill or electric bill. And they would bring the paperwork in because they didn't understand English. They would want us to translate it for them and then call on their behalf to advocate to not have it turned off, because at that time the moratoriums weren't in place. So those all got impacted, and having to do that a lot over the phone and reading the paperwork and continuing to advocate for their mental health care, because some of that stuff wasn't established to be telephonic or over video, just because there were so many pieces that were still to be established. So a lot of that stuff was impacted. Housing instability, as Lindsay mentioned, was a big piece for our patient population as well.
Yeah, and I'm sure all of those services really were hard to deliver when it's hard to even just get in touch with the patient.
Very much so.
So Lindsay, I think this is a great time to transition back to you to say, okay, so here we are now, October 3rd, 2020. What do services look like now at St. Francis House? So many months have gone by. Life in Boston has started to open up a little bit. We do have a little bit of a pause in Boston right now because we're seeing an uptick in cases. But what does life look like now?
Well, as you said, it has been quite some time now, so we've kind of gotten our bearings as much as we can. I mean, it's still a very kind of transient time where we could be going forwards or backwards depending on where it goes. But for the most part, we are back on site full time and offering all of our services, including food, but there's always modifications with it. So now we have front door triage. One of the really good things to come out of COVID was an update of the citywide database that we use. So we are able to, communicate more with our shelter partners, put in flags if they need further treatment or referrals for COVID, and contact tracing that way. There's a lot more plexiglass and masks are mandatory. Regarding, serving meals, we do still serve hot meals, but they are all to go. And we have decongested the shelter to 1/3 capacity. So around lunchtime, you will see a lot of folks, taking their lunch outside if the weather's nice. And while we are still continuing to do clothing donations, we have not been able to accept donations in many months because of, COVID and potential transmission. So it is more of an emergency basis, where before it was more of an individual shopping experience, I would say. So we are operating the best that we can, but it is still very reduced. Clinical and recovery is starting to get up and going again. And a lot of the case management services that we offer are currently shifted more towards housing stability and programs that are unique to COVID. We're trying to utilize them while they last.
So if you had to think about the top 3 lessons in your position that you've learned about COVID, so looking back and then, now looking into the future, does anything need to change in the future based on what you've learned over these past couple of months?
I would say one of the biggest things to come out of this is the emphasis on telehealth and telecommunications as a method to, interact with not even just medical providers, but government services and basic services that you need. And I think that the strides that we've made with that have been excellent and quite literally life-saving for my patients who are housed with complex healthcare needs. If they do have that technology, it brings down a barrier that was just so insurmountably high before, because just picture it before, if telehealth was not accepted and you were experiencing homelessness, then you have to be out of the shelter at 6 a.m. Maybe you don't have bus fare, maybe the bus is too busy or you can't get on, and then you have to get to the appointment and you don't have any of your vital documents to prove you are who you say you are. And it gets the wait times and why are you there? And it gets very muddled for a lot of people, like actually getting to the appointment to see the provider. There's so much that goes into just getting there. So telehealth for a lot of people has been life-saving. In relation to that, we need to continue to develop and expand upon telehealth and telecommunication access for everybody, because it's there and it's great, but it needs to be for everyone. And we are starting to do that within the shelter system. We've set up some telehealth rooms that they can be booked. So if a patient has a telehealth appointment, they can use that room and talk to their provider privately, even if they don't have their own cell phone. It just takes quite a bit of coordination. But I will say that telehealth and telecommunications are a must going forward. And another thing I would say is that collaboration is going to be our best bet moving forward. I am part of a consortium as part of my program. Actually, funny enough, when I first started my position, the parent program was called the Social Determinants of Health Pilot. And over time, it evolved into behavioral health community partners. And we have a host of shelter partners. It's St. Francis House, Pine Street Inn, Victory Programs, Casa Esperanza, the Mass Association of Shelters, Boston Healthcare for the Homeless, Boston Public Health Commission, and Boston Rescue Mission. So we have always been in communication, but when COVID hit, we were meeting every single day at 4 o'clock on Zoom. There was a couple hundred of us, and we would just talk about what was happening during the day and how we could plan it out. And out of that, we expanded equity and access in a few short months, more than I've seen in years, in spite of like the limited resources that we always work under. And I mean, a good example of this, as you mentioned in the beginning, is Project Bread and the emergency COVID food deliveries. So I mean, food is like a really good point for everybody to come together. It brings community. It's a necessity. And one of the things with COVID that was very prominent was I was not helping people with case management. I was not helping them with housing applications or Social Security applications. I was helping them find a meal for that day. How are they going to get that medication? Where were they going to sleep? What happens if the weather was bad? Like if it's going to be 100-something degrees outside, where are you going to go when everything's shut down? So it was very in the moment immediacy. And with the emergency food deliveries, we recognized that there was a lot of people that all of a sudden did not have access to food. So it was a huge collaboration. So like churches would have donations and food banks would have donations, but then we had to get them to patients who were medically compromised living at home. So we would be on the phone with Boston Healthcare for the Homeless. A nurse would be like, I have a patient. And then someone from like a case manager from Pine Street would go pick up the nurse from Boston Healthcare for the Homeless while we coordinated with the church to pick up the bag of food to bring it to the patient. And this happened every single week up until maybe about a month ago, when Project Bread has always been around, but they now have a hotline that you can call with an updated access list to food and shelter around you. And there is a lot more community access. The churches and community centers have done a lot.
That's so important. And just it's so important to recognize like what lessons that you've learned from this, you know, and just my personal hope that all those efforts continue into the future, even when there is a vaccine for COVID, because as you know, we all know, you know, COVID's here now, but you know, flu season's coming up, and you know, other things are going to come into the future. So just a reminder to everybody, our Q&A is open. I do have one final question. Jay, I want to bring, if it's okay, you into the future. In Upham's Corner, and what lessons did you learn about social determinants of health and the delivery of care and access to services? So what were the lessons that you learned going, you know, that you can take into the future?
I would say, you know, a lot of the topics that Lindsay already mentioned, technology is going to be the driver for us as well. Again, you know, we have been working with some of our community partners on creating some technology pathways to create as much access to the community that we serve and the population that we serve. But that is going to be one of the biggest pieces that we will continue to work on. The second is, again, how do we bring the care to the patient and collaborating with our partners? So many agencies do a lot of the pieces of care that we provide, and partnering with them because, you know, one-stop shop would be great to create the ease of access to the population.
Yeah. So it just really, really important points to think about for the future. Access to telehealth, access to technology. I do want to make a quick comment. A question and answer came in about our backgrounds, and just wanted to address those quickly. Dr. Lytle, when she is performing telehealth visits, she's in her home, and I thought that her background, that you were able to see of, you know, what her patients are experiencing when they see her for a telehealth visit. So if you are you know, fortunate to have her as your primary care provider and having a telehealth visit, this is her telehealth background. Lindsay's on ComAv with the green line going through the background, which I think we all, you know, the Law Tower, we all have such great memories. My favorite place in Sargent was 101. And I'm not there live. I can't wait to be there again live. And Jay's at the pub. which so many of us have such fond memories of the sandwiches that we were able to walk over and get. But I do know we did run over just a little bit. Thank you everybody for coming today, listening to our talk on COVID-19 lessons learned and taking it into the future. Thank you, Jay. Thank you, Lindsay. Thank you, Dr. Lytle, for being here with us today. And I hope everybody's able to tune into our awards ceremony later. Some very deserving recipients are receiving awards today. Go be you. Thanks everyone for coming. Bye.
Thank you.